are we in healthcare technology and healthcare AI, are we going after the right problems? Like, so if we start thinking about, well, what's the problem? That's the question that we're trying to define, is to answer some problem. Are we focused right now on the right things, or should we be redirecting our efforts as a community?
So that's a sort of a value judgment. Like, as a professor, I often feel that we go after the easy stuff, not because it matters, but because it's easy. So concrete example, I mean, so many groups using language models to, say, respond to patient messages.
Mm-hmm.
Everybody went in saying, oh, it's going to save us time. Well, guess what? There's studies out there saying you don't save time. And there's studies from, say, UC San Diego showing you actually spend 22% more time. And so in my mind, I think, again, it comes back to, like, have we defined the goalpost? Have we defined what is it we're trying to accomplish? And right now what I see is there's this mad dash for efficiency and productivity gains,
mm-hmm.
which, to paraphrase another professor here, Erik Brynjolfsson, it's falling into the Turing trap. We're imagining using AI to do things a physician already knows how to do. Like, we know how to respond to a patient message. All right, now let's have AI do it for me. But what we're not doing is imagining whole new ways of doing things now that we have AI. No physician can remember 1 million cases. A computer can.
Right.
So we can now use it to answer what happened to patients like mine. What are other such uses of AI?
So it's interesting. You're talking about the clinical decision support piece, and that's something that I worked on at XCures. We worked on it in advanced metastatic cancer patients, for instance. We actually found at the end of the day that the decision-making was easier than the data acquisition, right? Which just means we needed to figure out data acquisition first. I think we plan, and many people plan, to come back to this decision support idea. But going back to the fundamental efficiency play, one of the things I hear talked about a lot is the resource constraints that exist in our community now. I always think of it as like, we don't have enough doctors. We don't have enough nurses and support staff. We actually don't have enough facilities or equipment. And the population is aging, and in general, the health quality is going down. So and costs are going up. So we have like this perfect storm of every bad thing you could possibly imagine happening simultaneously at the same time. And in my mind, AI, right, and more than AI, think of it as a tool, but an ability to use the resources that we have now to essentially have more efficiency. So the efficiency piece to me feels like it has to be a really important part of this. How do you balance this kind of, doing new things with AI compared to just like, look, we only see 10 people a day. We actually really need to see 1,000 people a day. So how do we make that happen?
Yep. So let me try and address that. So let's start with the efficiency piece. Access is a problem, one of the topics you mentioned. Now let's go to the narrow example. Let's say I'm a doctor. I'm seeing 10 patients a day, and I have to do all of this late night work called pajama time from 9 p.m. to 10 p.m. Now I get AI. In-basket response, DAX a DAX nuance for transcription, or a bridge or what have you. And my 9 to 10 work is gone. Am I going to see new patients between 9 and 10? So access is not going up. I have become more efficient. I have less work, so I love it. But from a health system standpoint, we're spending more money on technology for the exact same 10 visits. So if you just do the math, productivity has actually gone down because we're putting in more resources to get the same output. And so often what I see is that this Turing trap behavior of using technology to do what we already know how to do, we're essentially paying off debt and calling it profit. Like, no, that's not how it works. What we have to imagine from whole new cloth. So for example, can I imagine an entirely new kind of primary care service, or let's say a dermatology service, where I have a multimodal AI agent as the first line of defense? You have something, you talk to it, you show a picture, and the only thing it does is this a problem or not? Like, do you need to see a human, or are you going to be fine? Nothing, and no fancy stuff. It's not going to try to diagnose me. If the AI says you're fine, I don't need to go see a human. Otherwise, it sends me to a human. If we do that, depending on what practice you're in, you essentially double capacity. Because half the time you go to a dermatologist, like, yeah, you're fine, not to worry. I mean, maybe a third, maybe 60%, depending on the practice, right?
Right.
But if we think in that manner, by combining or leveraging AI, we're actually increasing access.
I love what you're saying. It's basically saying, if I have visits which are unneeded visits, right? If I'm using the resources when I didn't need to use them in the first place, simply eliminating those is the same as creating additional opportunities for interaction, right?
Exactly. And so this goes back to how are we using AI? Everybody likes to talk about human in the loop. I think human in the loop is a terrible idea because then, well, not only you need the same number of humans in the loop, the human has this extra cognitive burden to check the AI.
Mm-hmm.
So the example I give is, when you get a CBC done, it is done by a machine and an algorithm gives out the differential count. When I trained in med school, we looked through a microscope and counted, like how many white blood cells did I see? If today you went to a pathologist and said, you have to manually verify every CBC, are they going to buy your CBC machine? Like, no. But the right way to use AI is to take work off of people. Like we try to create and build AI that is attempting to replace a human, a radiologist, or a pathologist, or what have you. Bad idea. What we should do is build AI to take off the stupid stuff.
Yeah, it seems to me that a physician, I'm just going to use primary care, and I'm not a physician, so I imagine these things, but there must be some number of visits that are essentially patient education visits, where the patient is coming to you and they're asking the same question, which, by the way, you must have heard 100 times beforehand. And it's a very important question for the patient. And they're asking it because they genuinely have a concern or want to know.
Mm-hmm.
But you're actually not delivering health care. You're basically acting as an education basis. And so it seems to me there's a huge opportunity around this triage, essentially, of the patient case and providing education and alternatives perhaps beforehand with, I think, again, we get back to kind of where we started this discussion, which is, I always laughed. I worked at a company called Archimedes many years ago. And we always used to say there's only kind of three things the thing can tell you is, should you walk to the doctor, run to the doctor, or call 911? Those were the only three, right, acceptable. But they all kind of led to the same place because you didn't want to say, no, you're all, don't worry about it, right?
Mm-hmm. Yeah. I mean, so I think, again, back to our community and ecosystem example, I think there's been enough academic progress in medicine, computer science, statistics, and so on. The technology works, quote unquote. What we have to figure out now is how to use it. We can use it in a Turing trap to try and replace human beings, and great, good luck. We might have a human in the loop, and now they have this cognitive burden of doing more. Mm-hmm. Or we can have human not in the loop, where the AI takes off work from the human. Call it augmentation, call it avoiding the Turing trap, call it avoiding digital services, like pick your buzzword. But we're essentially having the computer do things that a human had to do, and it was repetitive and wasn't exactly adding medical care or health care.
So do you have an example of someone who's either doing this today, and either a real example, or who do you think is going to move this part of the field forward next?
So I don't have a like pat example, but a company that I'm quite sort of excited about and watch is Cure Health, for example.
Mm-hmm.
And I love the way the founder articulates it. Like today, a clinician would manage a panel of 1,500 to 2,000 patients. What can we do with technology that one person can realistically have a panel of 5,000 or 10,000 patients? I just love the way the problem is presented, because it's asking the right question. That we're saying that we want to increase access. All right, now we want this one person to be able to serve 10,000 other humans. Okay, how do we do that? As opposed to, I'm going to do your intake for you, or I'm going to do your billing for you, or I'm going to respond to a message for you. Like, no, that's just like turning the crank faster. We're talking about building a different crank.
Well, I think you've really captured, I think, the essence of the question, which is, how are we going to do more, not with less, but with at least what we have today? I always think back to the oncology example. We have 13,000 oncologists or so in the country. We know the last ASCO measurement was now in 2025. So this year, because I used to be talking about this 4 or 5 years ago, but we're now at the year what they said, we're going to be short some 2,200. I might be getting the number slightly wrong, but it was several thousand. And nobody's going to magic up those oncologists. They just don't exist. So there's a whole now, we were already short, but now there's a whole population of people who just simply don't have, there is nobody to access, right?
Exactly.
And this is, to me, just so fundamental to the situation we have across the country and all the specialties that we're at.
We can't manufacture an oncologist overnight, but can we upgrade a local clinician to an oncologist level decision making using services like Atropos Health, XCures, and others who are compiling the essence of the learning of these 13,000 practicing oncologists in databases that right now neither patients nor other clinicians have access to.
So you describe, actually, I was talking to a friend of mine about this yesterday, and we were talking about public-private partnerships. I know I'm taking this to totally a different direction here, but the issue we were having with PPPs that we were talking about is how do you provide safe harbor for people to put data in? Because one of the things that's happened is people are holding on to data, and there's a couple of reasons I think people hold on to data. There's some commercial value, right, that people perceive around my proprietary data. It's going to make me special in some way. There's another thing which says, I don't necessarily understand all my data. I don't want anyone else to understand it better than I do. What if there's something in there that I don't want someone to find out, right? And there's this kind of interplay here where I think what's really changed, and I'll use an example here. If you think about what changed in the internet, right? The internet made the requirement for point-to-point pre-established connectivity go away. We suddenly had a network where anybody could talk to anybody, and we had to invent technology and rules and security platforms and encryption, and all of these tools had to be invented. We haven't thought that way in medicine. We still have Stanford and UCSF and MD Anderson, right? And some local clinic and some expert private practice concierge physician who's done it. We haven't built the knowledge networks that we're going to need to do this. And it's been talked about, to your point about this going back many years, the learning health system, right, has been talked about ad nauseum at this point, in my opinion.
Yeah.
So long. But are we finally at a time? Is that something we can actually do now? Is it going to happen?
So I think the technology exists. Technology exists. Like we talked about Curai, we talked about Atropos. There's 15 other companies, 10 other companies. But I think what we're ending up doing is imagine telephone exchanges. There was a time when a human plugged a wire into a hole in the wall, right? And what we seem to be doing in healthcare right now is building a robot to plug in and take out the wires faster without getting tired, as opposed to asking, should we just build a digital exchange? Right. And that is the fundamental sort of mental trap that I see happening. And it is happening not because people are not smart. It's happening because our incentives essentially steer people in that direction. Like there's no incentive right now for, say, the top 20 academic medical centers to put out a de-identified version of their data in a central repository so that every other clinician who's not an academic medical center can run a query of what happened to patients like mine. It's not a money problem. It's not that expensive to do. It's an incentive problem.